Just wanted to say good morning. Good morning. Happy 8th of March for all the ladies. Still in this region of Europe, we respect 8th of March as the very special day for women. So I wish you to be safe, to have health, to have success, and definitely I wish really a success of this very interesting, exciting session that we are starting. Okay, good luck and have a nice day and have a successful Congress.
Perfect, Ivo, thank you very much. And I think we should start right with our first session. It is Cardiologist for EV stroke interventions, and I would like to ask on stage Dr. Dobrin Vassilev.
Good morning, dear chairpersons, dear colleagues. I apologize for the delay. And which one I have to? Okay. So I have to speak about the role of cardiologists in treatment of stroke. I will start with this meta-analysis, which clearly demonstrated based on 12 studies about endovascular treatment of stroke of large vessel occlusion, the superiority of interventional treatment over the conservative or intravenous thrombolysis, regarding the better results in functional ranking score and improved death rates, and this is not for the cost of increased hemorrhage. It is logical with the good system of interventional cardiology nets which are developed during the years, that the interventional cardiologists with special training could be involved in the treatment of acute stroke. And this is a Polish study which was published 2 years ago, which in which this is from Katowice. This is a very large center, interventional center in the south of Poland, and they're one of the largest volume interventionalists in Europe in general. So this is highly experienced team where interventional cardiologists were involved in stroke treatment, and these are the results. As you can see, there was a small difference in effectiveness of procedure performed from interventional cardiologists, but regarding the death rates and functional results from the endovascular treatment, there were no difference, and this is the main results with the post-procedural data. The colleagues had around 30% 3-month mortality rate with 20% in-hospital death, which is relatively acceptable nowadays. And as you can see, there was in the multivariate predictors of mortality at 3 months, the person who performed the intervention was not an independent predictor of mortality, and the most important was the result at the end of the intervention. This is a comparison of this series with another series published where interventional cardiologists were involved in the treatment. As you can see, the results are compatible and relatively good. There were 2 guidelines regarding the stroke treatment, who and how should and when should treat the large vessel occlusions, and the big advantage of endovascular treatment is that practically we have much wider time window where we can perform these interventions. There are special requirements about the training of the persons who are involved in those procedures, and it is especially underlined that that should be one of the most experienced interventionists, not only in cardiac interventional procedures, but in carotid stenting procedures, and with the special training in endovascular treatment of stroke, with the requirements of special training. I think that for the high volume centers, there is not a problem to find maybe 2 or 3 interventional cardiologists who are performing these procedures and who can cover the requirements. These are data for interventional treatment in Europe. As you can see, unfortunately, Bulgaria is one of the latest and lowest as a coverage of stroke with treatment with endovascular procedures. And this is how we stay on the map of Europe. As you can see, we have one of the highest rates of strokes and the lowest rates of endovascular treatment per million population. The situation in general in Eastern Europe is similar. We started our endovascular treatment for stroke in 2022, and up to now we performed 60 patients. We treated 60 patients. This is the algorithm with which we applied in our center, with the which is centralized on the imaging, basically, mainly with first when the patient admitted. He had a CT, and depending on the time, the patient is directed to thrombolysis or with the activation of endovascular team. We achieved 75% TC2B and 3 rates, and at 10 months, the median follow-up rate, the survival of our patient was 63%, and this is a case example. This is a female at 66-year-old. She admitted with the symptoms 7 hours before admittance at the hospital with a very severe state. These are the results after the CT, and there was an occlusion of the right internal carotid artery, and after aspiration with Penumbra and Sofia aspiration catheters, we were able to achieve this final result. And it appeared that the patient, because this 66-year-old patient has also persistent foramen ovale, we made a transesophageal echo, and it was clearly proved, and the patient is scheduled for closure of the this anomaly, and the patient was left at the meantime on anticoagulant and PPI inhibitor. And in 2022, Petr Vidimsky just defined the concept that interventional cardiology should be involved. These are the general principles with following the same algorithm like in acute MIs with as fast as possible treatment because as in the heart, the time is muscle, the time is brain also. And I would like to finish just with a quick case, the patient who were admitted 2 weeks ago in our hospital with acute coronary syndrome, with the low ejection fraction, with the subtotal occlusion of the circumflex artery, subtotal occlusion of the diagonal branch, and high-grade stenosis with the spontaneous dissections, the distal right coronary artery. And the patient was treated because of the changes on the ECG and echo, and that was the final result. And the next day, the patient, early morning, the patient had aphasia and right hand plegia, and it was proved by he was immediately performed the CT scan, and the left MSA was occluded, so we immediately performed thrombus aspiration, and that was the result, immediate result. The patient was good for several hours, and at the afternoon there was a problem with the right leg, and again there was a emboli in the right iliac artery, so we had to treat this. He had previously occluded FSA, and we stented iliac artery with recovery at the flow to the right leg, and at the meantime the patient is relatively well with a slight paresis. So thank you.
Thank you very much for your presentation. Any questions from the audience? Yes.
Very impressive for a center in Bulgarian countryside. Grade 60 patients, I'm really impressed. Did you get financial reimbursement from the Bulgarian state for all penumbra pumps and all Sofia catheters? Thank
No.
you.
The short answer.
This is good to know, for them to know.
Yes, this is an investment from our hospital and developing of the center, and the only reason that we don't have reimbursement is because we don't have a habilitated neurologist in the field of ischemic atherosclerotic cerebrovascular disease. This is the only reason. We have trained interventionalists, we have neurosurgery, we have everything. This is the only reason why we don't have reimbursement for those procedures, despite that we are, I think that after the center of Dr. Alioski, we are on the second place as a number of endovascular procedures in Bulgaria.
Yes, this is impressive. And then how is it explained then that in Sofia, in Varna, and other huge Bulgarian cities, the rates of these interventions are so low? If the only need is for experienced neurologists at the center in order that the state finances these procedures, because it's so low that it's like shameful low. It's good that the audience knows this.
I think that this is quite a long discussion, and which is definitely concentrated on our Bulgarian problems, and maybe this is not the place to discuss exactly this point.
I think it is quite important, though, really,
Yes.
to see, because we know in all the countries how we went along with reimbursement.
Exactly.
And how reimbursement often is a hindrance. I remember in the UK we had to look because the treating hospital was saying, why should we pay because we have the main cost. Why should we do this procedure? And we had to do an analysis showing how many days less the patient stayed in hospital and how much less cost it was for the treating hospital. Also, one more comment. I think we're past the discussion, can interventional cardiologists or other interventionists do this treatment? That has long been shown. Yes, it is possible. I think the important part is the comparison against what would there be otherwise? There would be nothing. It's not about comparing one against the other and is one interventionist better than the other. It's about actually starting to provide a service. And I also saw the UK on here also, yeah, same color in red. Yeah, so it is really about time to step up and see how can we work together and provide a bigger service.
I completely agree. I mean, the most important thing is to actually get the legislative bodies and the decision makers behind the program, because once you do have your reimbursement and you do set up your network, actually training professionals is not that hard anymore. I mean, you have big centers even nearby. I mean, luckily, even I have one fellow from Bulgaria in Budapest who is trained. We have 760 thrombectomies a year. So what we have set out as a training requirement of assisted and performed interventions is basically something that can easily be accomplished currently in a large volume center. So, but the main issue is, if you train your personnel, will they be able to practice their profession? And it doesn't really matter what the original profession was, whether it's cardiology, neurology, or radiology. What is important is that they get their hands-on training in high-volume centers, and they get the sufficient experience to be able to practice safely. And that is the key, basically. So if you do get your reimbursement, then training the personnel is now much easier than it used to be, like 10 years ago when the centers had much lower volumes, I believe.
So what I would like to add to this discussion, my name is István Sikora, I'm from Budapest, and is that I guess that it's very nice starting doing these procedures more or less regardless of what is your training background. But starting without arranging the background that is reimbursement is not a good idea. What I'm going to tell you is that we had reimbursement for intra-arterial thrombolysis back in 2000, 2000. And that has been upgraded for thrombectomy in 2013, 2 years before the big studies came around. And we had a legally arranged training system starting also in 2013. So by the time thrombectomy came around, by guidelines, the whole setup was already there. I guess what you really need to do is to talk to the officials, to the decision makers for the reimbursement, because without that reimbursement you cannot do anything.
In Bulgaria, there is a reimbursement of endovascular treatment. Our center is not certified just because of some interesting reasons, and practically we started, and probably we will, in very, let's say, close time, we will obtain officially approval.
I will summarize the problems in Bulgaria because, yes, in the moment we have 4 centers in Bulgaria. Varna, Sofia are
not enough.
3. Yes, and the future is to build another, probably to become 10 centers, and one of them probably will be in Ruse, in your hospital, but it is the future. In Bulgaria, we solve the problem slowly, like ex-socialist countries, and the things is going very slow.
Therefore, I think you have to go to the public and ask all the politicians, what are the expenses for disability and for treatment in time?
Of course.
Because disability is also very expensive, because when you have paresis for the rest of your life, yes, and you need help and so on, that's also not cheap. And so that you have to make a calculation. Is it not better to invest in health than to care than from the disabled people?
I fully agree. There is a lot of papers of cost effectiveness of the treatment. We don't speak about that, but yes, I agree that it's necessary to speak with the insurance fund, with the Ministry of Health, but probably it will take the time. But when we start in the beginning, the patient paid everything for the procedure. Now we have some reimbursement about the procedure. That it means that we go better and better.
Well, I definitely want to congratulate you on what you have set up. It's an amazing thing. I believe that very often you need to just start. If you always wait until every duck is in a row, you will never get going. That is the principle that I've always followed. We just started it, we just did it, and in our cases, reimbursement did follow eventually. Congratulations on how many lives you've saved with what you have set up.